Okay, and we start chatting about the spinal nerves. Okay, spinal nerves originate in the CNS, as you can imagine. Most of them are mixed nerves. Ventral roots of spinal nerves, which you can see here, okay, are motor. Dorsal roots are sensory, okay. Nerves themselves are pretty short. Essentially, the spinal nerve is something like this, okay. That's it. That's that extension. That's the whole spinal nerve. Because spinal nerve, shortly after it comes out of the vertebral column, see those vertebral columns, the models? Do you see the yellow protrusions, projections? Those are spinal nerves. That's it. So it just comes out and immediately branches. It branches into the ventral and the dorsal rami. Rami is plural. Ramus is singular. So ventral ramus means ventral or anterior branch. Dorsal ramus means dorsal or posterior branch. Does it make sense? You have 31 pair of the spinal nerves. All parts of the body are innervated. Obviously, head is innervated by the cranial mostly, okay. Some parts of the neck are innervated by the accessory. Other than that, every part of the body is innervated by the spinal nerves. You have 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Okay. There you go. Now, if you would compare the number of spinal nerves to the number of vertebrae, you will notice that we have 12 thoracic vertebrae, okay? We have 5 lumbar vertebrae. We have 5 fused sacral vertebrae. We have coccygeal vertebrae. But we have 7 cervical. So why 8 cervical nerves instead of 7? Why the number of cervical nerves doesn't match the number of cervical vertebrae? Explanation is pretty simple. In every case, you may think of the nerves like this. You have first thoracic vertebrae. Under it, you have first thoracic nerve. Does that make sense? In case of cervical, you have 7 nerves that are under the vertebrae. But very first one is above the first cervical vertebrae. Does that make sense? So you have 8 cervical, and then it matches the number of vertebrae in each part. Okay? So we call them cervical spinal nerves, thoracic spinal nerves, lumbar, sacral, and sacral and coccygeal usually, together, called sacral. Ventral rami, only ventral rami, they form plexuses. Plexus means that the nerves, the branches of nerves, become interconnected. You can see the cervical plexus, the brachial plexus, the lumbar plexus, and the sacral plexus. And you can sort of see at this point that nerves start to branch and branches start to merge, which means fibers that originate in any ramus can reach the certain part of the body via several ways. Think about this. I usually compare plexuses to driving. If you want to get from here to downtown Cleveland, there's definitely more than one way you can take. Does it make sense? So even if I-90 is closed, you can still get there. Okay? Same goes for plexuses. Think about this. You have several, so you have nerves, say cervical nerve 2. And there are fibers that go from cervical nerve 2. Some fibers go to the occipital region, okay, some fibers go to the auricular region, right? Now, fibers from occipital nerve 3 also go to all those different places. Does it make sense? So you have fibers from several spinal nerves that innervate a certain part of a muscle or a certain part of the skin. So the signal can reach the muscle via several ways. So even if there is a damage to a spinal nerve, this damage will not completely paralyze the muscle. Is that clear? It is not? No? Okay. Again, using the analogy of the driving, okay? You have several destinations along I-271. And you need to get to the downtown Cleveland. You can get to downtown Cleveland from any of those destinations. The paths are going to be different, but you still can get, right? You can get there from Beechwood, you can get there from Highland Heights, you can get there from Mayfield, right? So you have cervical nerve 1, 2, 3. Some fibers from the nerve 1 will go to the occipital region of the head. Some fibers from the nerve 2 will go to the occipital region of the head. Nerve 1 gets damaged. Does that mean that you totally lose sensory perception of the occipital area? No, it doesn't, because you still have nerve number 2. They organized in plexuses. They are interconnected. Got it? Now, dorsal rami, obviously, you can see here. Okay, dorsal rami do not form plexuses, first of all, and dorsal rami innervate just fairly short, fairly narrow strip of muscles in the back, and they deliver sensory information, somatic sensation from those muscles. Are we clear? Can you see that? So you can see the huge ventral rami and rather small dorsal. We got it? Dorsal rami do not. So first plexus is cervical. First, well, mainly 4 cervical nerves, okay? A little bit of number 5. Okay? So there are 2 nerves, cutaneous, which are sensory, and motor branches. They run deep and they control muscles. The function of many cutaneous branches can be easily guessed from the name. Lesser occipital nerve, which you can see right here, okay, generates in C2 and C3 and innervates the occipital region of the head. That make sense? Greater auricular. Auricle means ear. So let's do it this way. Greater auricular. Here. Okay? Ear. Transverse cervical. I cannot show it on the picture. Pretty much anterior part of the neck. Also C2, C3. So you can see how these 2 nerves, cervical 2 and cervical 3, their branches reach different parts of the head. Okay? And supraclavicular, what's the clavicle? The collarbone, right? Skin of the shoulder and over the clavicle. Now, supraclavicular is lower. Pretty much goes from top to bottom. Okay? Lesser occipital, greater auricular, transverse cervical, supraclavicular nerves. Motor branches. Ansa cervicalis. Ansa cervicalis can be easily recognized as a sort of a loop here. Okay? Ansa cervicalis branches further and innervates deep muscles of the neck, infrahyoid muscles. We didn't talk about the function of muscles yet, but let me tell you something. Those muscles are responsible in swallowing and speaking. Does that make sense? They control your pharynx pretty much. Segmental branch. Again, muscles of the neck and parts of the head. So segmental branches of the cervical spinal nerve will control your neck movements, shoulder elevation and depression, turning your head left and right, elevation of your scapula, so again, shrugging, okay? Does that make sense? And perhaps these two guys, ansa cervicalis and segmental, segmental nerves originate in pretty much the entire cervical region. Ansa cervicalis originates, fibers come from C1 to C3, phrenic C3 to C5. So it's probably the most important nerve of the entire cervical plexus. Yep. Phrenic is C3 to C5. This is why. It controls diaphragm. If phrenic nerve is paralyzed, person cannot breathe. Remember, we had a conversation about poliomyelitis. How this virus damages the ventral horns of the spinal cord. Well, guess what? If it damages the ventral horns at the level of C3, C4, C5, those ventral horns where lower motor neurons of phrenic nerve originate. So the person ends up with an iron lung or dead. Does that make sense? Brachial plexus. Very complex in terms of the structure. You won't need to know things like roots, trunks, divisions, okay, and cords. No worries about that. You should know the nerves though. So brachial plexus, as you can guess from the name, controls the upper limbs, right? So injury to the plexus, now you can imagine this. The higher the injury, the more proximal injury to the spinal cord will affect the upper limbs harder. Say if there is an injury that affects the entire trunk, okay, it's going to be bad because there are many fibers that innervate upper arm. It has many branches. So axillary branch innervates the deltoid muscle, and you will see that I will focus mostly on the motor function, and the reason is pretty simple. Think about this. if auxiliary nerve, okay, controls muscles of the shoulder, deltoid muscles, what would be, where would it take sensory input from? Auxiliary nerve controls deltoid muscle. Where would it take sensory input from? Huh? Say again? Well, which part of the hand? It's not a tricky question. Same place, yeah, shoulder. Does that make sense? Because it kind of counterintuitive and it's not going to happen. You know, motor control here and sensory input from here. Do you see what I'm saying? So I focus mostly on the motor controls. And in your practice, believe me, patients will come with the complaints, doctor, I cannot raise my arm. Rather than, doctor, I have some numb sensations in my shoulder. First thing that they're going to notice is the motor dysfunction if the nerve is damaged. Does that make sense? So that's why I'm focusing mostly on the motor functions. Oh, and auxiliary, the brachial plexus, second portion of cervical, and a little bit of the first thoracic nerve. Okay? Scapular, suprascapular, subscapular, dorsal scapular. What would they control? Movement of what? Shoulder blades. Does that make sense? Dorsal scapular, muscles in your back like rhomboids that bring your scapula together. Subscapular and suprascapular, 4 rotator cuff muscles. Teres major, subscapularis, supraspinatus, and infraspinatus. Okay? So you look at the name, and my purpose is not to trip you over, but to ask you a question, something like, which of these nerves is likely damaged if the person's shoulder movements are impaired? Does that make sense? So I have to think, okay, which nerves control muscles responsible for the shoulder movements? Auxiliary, dorsal scapular, subscapular, and suprascapular. Those 4. Does that make sense? Long thoracic. This one controls serratus anterior muscle. Okay. Pectoral explains itself. You have these 2 branches, lateral and medial pectoral. Pectoral nerve controls muscles of the anterior trunk. Pectoralis major and minor, right? Does that make sense? Do you follow me? I'm going to relieve a little bit. I'm going to relieve your pressure a little bit in the end when I will tell you what to focus on in terms of the anatomy and physiology of these nerves. Okay? Now, these nerves are fun to talk about. Musculocutaneous, which is a lateral nerve of the upper arm, and it goes like lower. You can see that these nerves, they go from the upper part of the, they go from top to bottom, okay? So auxiliary originates in C5, C6, pectoral originates lower, C5 to even T1, C5, C6, C7, C8, okay? Scapular nerve, C5, C6, okay? Go lower. Now, nerves that control your arm. So far, we were talking about shoulder, rotator cuffs, and pectorals, right? Now we're talking about the arm controls. Let's see what you can do with your arm. You can do this. You can do this. So you can flex, you can extend. Same goes for the palm. You can flex your fingers, you can extend your fingers. Same goes for the wrist. You can flex wrist, you can extend wrist. Does that make sense? So we're talking about flexors and extensors. Musculocutaneous nerve controls the flexors of the upper arm, mostly biceps brachii. So if you damage musculocutaneous nerve, what you won't be able to do? Flex. Does that make sense? Median nerve. Flexors of the forearm. Okay? What flexors of the forearm do? They do wrist flexion and digital flexion. Here's what you cannot do if your median nerve is damaged. Pincer grasp. Does that make sense? Of course, you know, you cannot do this. Ulnar nerve. You can see the ulnar nerve is the most median nerve of an arm. You can see it right here. So ulnar nerve controls the rest other three fingers. Okay. So imagine if the ulnar nerve is damaged, you cannot form a fist. Does that make sense? So you can do this, but these fingers are not controlled. Does that make sense with it? It's also funny bone. When you hit the funny bone, you hit ulnar nerve because it runs next to the process of the humerus. That makes sense. The last one is radial. So radial nerve controls the extensors. Okay? If extensors of forearm do not work, what's going to happen? Yeah, you can do this. Right? You also cannot do this. So radial controls both triceps brachii and a bunch of extensors on the posterior aspect of your arm. Sometimes I call it the nerve of the drunk people. People get drunk and they sit on the, in front of the table or on a chair and like fall asleep like this. Constant pressure on the radial nerve will temporarily paralyze it. And people just wake up, and they see this and they cannot elevate their hand and just start to freak out. Okay, it comes back eventually. Does that make sense? For me, it happens, I paralyze sometimes pretty much the entire brachial plexus. When I wake up, I cannot move my entire arm. It takes a few seconds for it to come back, because if I sleep like this, in some horrible position. So that condition, when the wrist is down, is called wrist drop. Wrist drop. Okay? Does that make sense? Lumbar plexus. 5 lumbar spinal nerves. Lower limb. Now, you have to understand that lumbar plexus innervates the femoral region, lower abdomen, hips, buttocks, genitalia. Okay? So femoral, pretty big. Okay? Obviously, anterior portion of your femur, okay? Quadriceps. So it's going to be flexion of the hip and extension of the knee. Does that make sense? Femoral muscles, anterior femoral. Obturator. Smaller nerves, also L2, L4. Adduction of the leg. Now, since we didn't talk about that yet, and we're not going to talk about it for a while, but for, you know, our conversational purposes, this is flexion, this is extension, this is abduction. Like, you know, you abduct, you steal something away from the body, abduction. This is adduction, you add limbs to the body. So for legs, abduction, adduction, flexion, extension, extension, flexion. Does that make sense? So we can just operate in these terms. So obturator will be responsible for abductions of the legs. Again, it's a hip movement, right? That makes sense. Gorgeous. If you see the name cutaneous, what does that mean? What does sensory, right? Sensory nerve. Skin doesn't have a lot of like important skeletal muscles to my knowledge. Okay? So, and it tells you lateral femoral. So, right here, lateral aspect of your upper leg. Does that make sense? Iliohypogastric. Ilial region, where? Right here. Hypogastric. Well, sort of here. Lower abdomen. Lower abdomen. That's what it controls. Abdominal wall, internal obliques and transversus abdominis. Okay? Ilioinguinal. Ilioinguinal. Absolutely lower, the lowest abdomen. Does it make sense? And sensory inputs go from the same part of the body. Okay? Genitofemoral. Sensations from the scrotum in males, labia majora in females. Anatomically, developmentally, labia majora and scrotum are the same things. When they develop, it's the same thing. Okay? Anterior thigh, we're talking right here. Okay? This part of the thigh. And it also controls the cremaster muscle. What it does, listen, cremaster muscle will pull up testicles in a male. It's a skeletal muscle. When it's too cold outside, cremaster muscle contracts and pulls testicles in. Does that make sense? When it's hot, leaves, drops them out so they can cool down because it's important for the sperm maturation. Does it make sense? Now, a little cool application. Since genitofemoral nerve innervates the anterior thigh, including the sensory branches, it's responsible. You can check the functionality, genitofemoral nerve, using cremasteric reflex. If you move the blunt object upwards on this portion of the thigh, and you will observe the ipsilateral testicle. Testicle should be pulled up. Does that make sense? So you do this and testicle goes up. I mean, it's not going to like jump, through the roof. It's going to move a little bit. Blunt up, like, it's usually not a finger, but some sort of a pen, something like that. Just move it. So you got to have sensory input, and the testicle is being pulled up. Now, I'm kind of giving you idea what is clinical relevance, okay? Because look, that's genitofemoral. It starts at L1, L2. If person shows no cremasteric reflex, what does that mean? Yeah, well, I mean, not the spinal cord, but nerve damage. Some sort of a nerve damage to genitofemoral, right? Maybe spinal cord damage, it's totally possible. Maybe this person has neurosyphilis. That is. That's going to be, yeah, tertiary, yes. So essentially, if you have damage to the roots of the spinal nerves in the lumbar region, that will horribly affect gait, because you cannot properly control your hips, you cannot properly walk. That makes sense? If it's femoral nerve, you may not be able to extend your knee, for instance. Sacral plexus, lower limb and the buttock. Okay? The largest nerve can be found in the sacral plexus, and it's called sciatic. Yep. That's the huge sciatic nerve, which is essentially a combination of two smaller nerves. It's two nerves, common fibular and tibial, that are wrapped in the same sheet of connective tissue. If there is an injury to the sciatic nerve, which can come from herniated disc or unlucky fall or improper injection in the buttock, it's excruciating pain. Okay? And if nerve gets inflamed, and from time sciatica can come and go. If sciatic nerve is transected, then it leads to the paralysis of the hamstrings. So there can be no flexion of the knee, okay, nothing like that. There is no flexion in the ankle, flexion or extension, whatever, if the entire nerve is damaged. Does that make sense? More frequently, the portions of the nerve are damaged. So if this is the tibial branch or tibial nerve, okay, then tibial nerve innervates the posterior aspect of the lower leg, right here, okay, the calves. That makes sense? If calves are paralyzed, it means the person has no plantar flexion. The person cannot do this, okay, cannot do this, which means the person will have so-called shuffling gait. We clear? If the common, if common fibular nerve is damaged, common fibular nerve innervates the anterior portion of the lower leg. So there will be no dorsiflexion. It's called foot drop. Does that make sense? So that's common fibular. Other important nerves, gluteal nerves, control the buttocks. That's pretty obvious, right? Posterior femoral cutaneous, sensory inputs from the posterior aspect of the thigh. Pudendal, muscles of the perineum, okay. External anal sphincter, which is voluntarily contracted. It's a skeletal muscle, external anal sphincter. That's the part of the defecation that is controlled. It also brings the sensations from the external genitalia and anus, like clitoris or labia minora, okay, even vaginal mucosa. Does that make sense? So pudendal nerve innervates pretty much genitalia and controls external anal sphincter. Okay? Now one thing kind of I'm jumping over the barricades on your side and giving you a little hint. There's going to be an anatomy exam. When you identify nerves, lumbar and sacral plexuses look a lot like each other. I'm going to tell you what you should pay attention to. This guy, is he face, or is it, well, is this facing you, or is this turns its back to you? Faces. Here you can see this thing, this person's back. Does that make sense? When you see the back and it's shown from the back, it's the sacral plexus. Does that make sense? Thoracic nerves. So far we got, look, cervical plexus, the upper neck. Brachial plexus, the lower neck. Lumbar region, lumbar plexus. Sacral region, sacral plexus. Thoracic nerves are not organized into the plexus. Okay? They do not form plexus. They form so-called intercostal nerves. What they innervate? Thorax. The ventral rami innervate thorax. Okay? And the upper abdomen. Because remember, lower abdomen is innervated by iliohypogastric and ilioinguinal nerves of the lumbar plexus. Does that make sense? So instead of forming this plexuses, each ventral ramu, ventral ramu of the thoracic nerve innervates like a strip of muscles. Does that make sense? And that brings us to the concept of dermatomes. So dermatome is the area of the skin innervated by the, I'm not reading, innervated by the afferent branches, cutaneous branches of a particular spinal nerve. Does that make sense? Now if you look at the Jude on the left, you will see that, for instance, strip of muscles that includes intermediate part of the arm, your shoulders, and the very upper thorax, pretty much like the sternal region, upper sternal region, upper thoracic region. It's going to be dermatome C5. What it means? Dermatome C5 means that the fibers from cervical nerve number 5 innervate that strip of muscle. Does that make sense? You can see that thoracic nerves make perfect sense, you know, anterolateral thorax and abdomen. Cervical make perfect sense. Upper limbs, neck, occipital region. You can see that only cervical nerve 1 doesn't form any dermatomes. Okay, the entire anterior portion of the legs is the lumbar nerves. Posterior aspect, sacral, which kind of narrow down around the anal orifice. Okay. External genitalia, sacral. Does that make sense? Why it's so important? What's the clinical importance? What do you think? Person comes in with suspected spinal cord injury. You start poking. Does that make sense? Start poking in the person's legs, going up. Do you feel anything? Do you feel anything? Do you feel anything? Do you feel anything? Now you feel? What level is that? Say it's here. Say that's approximately T8. So you have injury in thoracic area, somewhere at the level of T8. You have to understand, dermatomes are not like chiseled in stone. It's not like you have some magic light. You're projected in a person with just lines of dermatomes. They're pretty fuzzy because of the plexuses. Does that make sense? So what you may encounter on the exam, no numbers, picture like this, no numbers. I show you here and ask what dermatome is that? And you will have answers. It is 10. What you're going to get in the answers, it's not going to be T8, T9, T10, or T11. You would have to say lumbar 1, T10, T2, or C8. Does that make sense? You have to realize the numbering order. Okay? Does that make sense? So please know the distribution of dermatomes. It's all in the lab. For the nerves that we talked about, the spinal nerves, don't sweat too much about the exact origin. Ansa cervicalis starts at C1, C2, C3, or C4. Give me a break. I'm not going to ask you this. Okay? But I give you a nerve, recognize the plexus. Number one. Number two, most important, function, what it innervates. And I will be focusing mostly on the motor function. Does that make sense? So let me get a question. If the patient lost control over the flexors in the upper arm, which nerve is affected? And you must recognize that it's musculocutaneous. Did I make myself clear? Awesome. Lab is on the blackboard. There are actually 3 of them. One lab number 7 is nerve anatomy and the cranial nerve anatomy. Lab number 8 is spinal nerve anatomy. Lab number 9, we didn't cover it yet. Okay? Let me pause it and just